One. Please start, sir.
Hello, good evening, everyone. I would like to welcome you all to the today's virtual conference on oncology update. With immense pleasure, I would like to invite Dr. Manish Sharma, who is the oncology medical oncology unit head in Action Cancer Hospital, Delhi. For all the welcome introductory note, the stage is all yours, sir. Now over to you, Manish Sharma, sir.
Thank you so much. Good evening, all, and my warm regards to all these speakers and all the colleagues who have joined in here at this evening. And today, the oncology update will include the topics on lung cancer. The lung cancer is the most common cancer worldwide. We all are aware about it, and the cases and incidents are increasing. And on the top of that, I think this is the cancer in which the maximum amount of work is being done, and a number of newer drugs and molecules are coming day in and day out. And we have new potential biomarkers as well, like ctDNA and circulating tumor cells nowadays, on which Dr. Bohar will be talking about. Then we will be going through the real-world evidence of the third generation oral TKI, safety of EGFR TKI, and then very importantly, the data from latest WCLC conference, which concluded just a few days back, 2023, talking about FLORA-2 trial by Dr. Abhishek. So we have speakers, Dr. Bohar, Dr. Praveen, myself, and Dr. Abhishek Yadav. I welcome Dr. Bohar Shafi. He is Chief Medical Geneticist at One Cell Diagnostics, and he will be taking upon the topic of harnessing the potential of liquid biopsy, ctDNA and CTC, the revolutionary the dynamic duo revolutionizing the oncology. I welcome you, sir. The stage is all yours. Thank you so much.
Thank you so much for introduction and giving opportunity for us to present what we do at One Cell Diagnostics. Without wasting time, I'll just dive into what I'm going to talk about. That's harnessing the potential of liquid biopsy, ctDNA as well as CTC, what we call as dynamic duo, which is revolutionizing oncology. To set the stage, if we look at what data we see here, a decade ago and what we are going to see in a few years, this data clearly shows that we are going to see more and more cancers. And what we can do is, that's where the precision oncology, precision medicine plays an important role, and prospective incorporation of molecular profiling is definitely transforming the global cancer care. The reason for that is the cost of the technology is falling down. Technology has evolved drastically, and we are improving the patient outcome, and therefore we are increasing the value to the patient's life. But the question always remains there, should every cancer patient be profiled? So let's see what data says about that. The first thing is, biomarkers, and which are very diverse, and how we use these biomarkers in routine practice. We use it for diagnostic purpose, prognostic purpose, predictive purpose. Now we start using them to measuring the response to a particular treatment, monitor the disease, and risk monitoring, etc. So coming to the direct topic, to the CTC and ctDNA and these dynamic duo, what are these? CTCs are circulating tumor cells. Now, what I can say is these are live bombs circulating in the blood, and it has a lot of information in terms of a diagnostic, prognostic, and predictive as a biomarkers. And these CTCs, actually, when they get into the blood circulation, they become a seeds for the growth of additional metastasis progression. And, the CTC count in the blood actually provides unfavorable prognostic information. Whereas ctDNA, on the other side, these are circulating tumor DNA. Sometimes we call it cell-free DNA, floating into the blood, released from the blood, circulating tumor cells as well as primary tumor, and they contribute into actually, the disease burden, to measure the disease burden. So how can we use that in the real practice? The CTC, first let me make a difference between what is ctDNA as well as cell-free DNA. Cell-free DNA is the DNA which is released in the blood from all type of cells, including tumor cells, due to apoptosis and other mechanism. ctDNA is the small fraction of that cell-free DNA, which is mostly released from the tumor cells. And this is very small amount, about 1 to 2% of the total cell-free DNA. Therefore, it becomes needle in the haystack, in identifying that. So thanks to technology, we have now technology where we can detect these ctDNA molecules in the blood sample, therefore help oncologists to understand what is happening to their patients and how to plan their treatment. So how we can use this ctDNA and CTC, what are their benefits? We can use ctDNA in longitudinal monitoring. Regular assessing of CTC and ctDNA load actually helps an oncologist to get the dynamic insight to understand response to treatment, and possibly there is a potential of disease relapse, recurrence, progression. The ctDNA and CTC can be used as a minimal residual disease, like one of the tests we offer, I can monitor, ability to identify the small amount of ctDNA and few numbers of CTCs can help us to early detection of minimal residual disease. What is minimal residual disease? It is the disease which cannot be detected by PET-CT scan. Therefore, it takes long time to detect by PET-CT scan, and by the time patient is detected by imaging techniques, the disease has progressed. And these ctDNA and CTC can help us to identify whether treatment is working or whether treatment needs to modify it. And they play a prognostic implications as well. So how we use this ctDNA, kind of a risk classification, this is not in the guidelines, but there could be ctDNA and CTC both positive, and therefore patient need to a close follow-up treatment. Either ctDNA or ctDNA could be negative, CTC could be positive, or ctDNA could be positive, CTC could be negative. In both the cases, again, close follow-up is needed. Or in the last case where both are negative, and then therefore we may go as per standard of care. Why we need a liquid biopsy? The first problem we have, tumor is heterogeneous. And if we go tissue biopsy, it may not be the full representative of the tumor, and therefore it impacts the success of the tissue biopsy. There could be heterogeneity within the primary tumor, between the metastatic sites, and that's where this liquid biopsy plays an important role to identify something which may lead to resistance to the treatment. For example, 53-year-old female ovarian cancer patient who has done NGS earlier, where they have found MSI unstable, but when it was confirmed by IHC, it was stable. Then there were two genes, ERCC2 and TP53, which were mutated. And based on NGS earlier result, they've started treatment with immunotherapy. Patient progressed after 3-4 months. And it was discussed in one of the tumor board where we afford it, and we took both tissue as well as liquid. In tissue, we got the same result as previously, showing the concordance between the lab and this. But in the liquid, what we found is BRCA2 mutation, which was missed in the tissue because tumor is heterogeneous. That tissue content was not there, but this BRCA2 mutation was there. And suggesting patient could benefit with PARP inhibitors. But more importantly, there was STK11 mutation, which leads to resistance to immunotherapy, and suggesting why patient has progressed on immunotherapy. Actually saved them, if it would have been done earlier, they would have saved that 3-4 months of cost of immunotherapy. Second problem is tumor is evolving. If we have a tissue which is older and we may not get the correct current informations, this is one of the data where they have done the comparison tissue and liquid blood. And what they have found is if tissue is more than 6 months old, you lose 40% of information. And there was a statement from, ASCO, even for patients who are able to undergo traditional tissue biopsy, a liquid biopsy may be safer, quicker, and more convenient, and perhaps more informative. So what it is suggesting that, if tissue biopsy is not possible, or if it is very old, we should, often say that, we should prefer go over liquid biopsy to get a current information at a molecular level. For example, this is another 69-year-old metastatic, CRPC who has already received a series of treatment And when we did tissue versus liquid, what we found in tissue BRCA2 mutation, HRD was high, TMB low, MSI low. When we looked into the ctDNA, we found BRCA2 and HRD high, but we found RB1, a rare type of a mutation in this, which was not there in possibly, the reason was there in when we looked at, there was a 7 months difference between tissue and the liquid. And this patient actually showed resistance to PARP inhibitors because that resistance was driven by the RB1 fusion. So that's how it's explaining how you may find resistant mutations even from the liquid, possibly which could be due to tumor evolution or tumor heterogeneity. So there are a lot of studies suggesting that in a role of ctDNA, there's one of the study more than 20,000 where they have done a different type of cancers. Even we can find this ctDNA now in glioma, where we have often question of that, whether it pass, blood-brain barrier. So why ctDNA is an important biomarker? We know we are using protein-based biomarkers like CEA, which has a half-life in months together, but whereas ctDNA has a half-life within minutes to hours, and therefore it gives a current information, and it has been shown in several such studies. If I look into this year ASCO data, there were 370 abstracts on liquid biopsy using ctDNA. And if we go about a decade ago, there were only 10 abstracts in ASCO. In 370 abstracts, 9 abstracts we have published on various disease and various options where we show that the importance of liquid biopsy in different cancers. So one of the example is, the role of comprehensive, molecular profiling in non-small cell lung cancer EGFR positive, how we can use that in a monitoring tool to find the response to therapy and disease progression. So just put a 2 case out of that study. It was done along with Tata Memorial Hospital. This is one of the case, there was this ctDNA based markers were identified around 50 days earlier before imaging could detect that there's a progression in these patients. Whereas in other case, you could see that stable at ctDNA load and suggesting the patient was a stable disease. Another case, again, non-small cell lung cancer, where we have done this another study where we have found the selective markers which leads to resistance to tyrosine kinase inhibitors. For example, what we see here, how these patients show resistance to tyrosine kinase inhibitors. So how we use this liquid biopsy, in treatment line, it varies based on, if this cancer is a localized cancer, and it can be used, immediately after surgery, or even before surgery when you are defining neoadjuvant treatment, how long neoadjuvant treatment has to be given, and find minimal residual disease. And if it's a metastatic condition, how we can use liquid biopsy to monitor the response, to identify the progression and find the resistance mechanism. So there was a very beautiful paper which is explaining that, how this liquid biopsy is becoming important, how we can use the ctDNA as a way to detect minimal residual disease, and how it can help us to identify the resistance to therapy, how it can help us to define whether there is need of adjuvant therapy and there is a possible recurrence. More importantly, this is very important that longitudinal testing is actually improving the sensitivity. For example, if the test is negative at the first time point, does not mean that there's no disease. It has to be followed by at least 1 or 2 more time points to make sure that there is no disease or there is disease which may increase, like what you have seen. So longitudinal monitoring increases the sensitivity. So this is one of the study where they have shown that how ctDNA can help to define whether we need to extend total neoadjuvant treatment, whether surgery is needed, whether increased surveillance or adjuvant chemotherapy is benefiting the patients in terms of follow-up studies. So, for example, this is one of the famous trial dynamic studies in colon cancer, where they have shown that ctDNA guided approach is actually helping in stage 2 colon cancer to reduce new adjuvant therapy use without getting recurrence for this. So it can help us to identify who may need surgery or who may need adjuvant treatment. So, for example, I have put it simplified two cases here, case 1 and case 2. If we look at here, both are, locally advanced rectal carcinoma, T3N2. Here is T4. And slight difference between these two cases at a clinical level, but when we look at the CEA as a biomarker, it is not elevated in case 1, whereas ctDNA is actually positive before surgery, whereas the other case, both of them came positive, but post-surgery, when we do follow up, CEA, ctDNA has increased, and actually this patient has recurred, whereas this patient post-surgery, both ctDNA and CEAs were negative, and patient was there was no recurrence. Explain that, how it is helping to define adjuvant treatment requirement post-surgery. And ctDNA analysis actually helps us to detect a minimal residual disease and predict recurrence. This is one of the study where they have done the stratification of patients based on ctDNA positive and negative, and you could see that clear difference in the overall outcome of the patient. Whereas if you do the stratification based on the clinical pathological characteristics, you could see that there's not much benefit as in the ctDNA guided. There are a lot of studies, in breast cancer, they have shown that, radiation chemotherapy response using liquid biopsy, actually locally advanced head and neck cancer. It has been used to define as a surrogate biomarker for disease burden in breast cancer, in bladder cancer, and many more cancer types. So, for example, in head and neck cancer, it has found that, using ctDNA-based analysis to detect minimal residual disease actually has found 122 days lead time using ctDNA compared to, standard imaging techniques to identify clinical progression. So, now so far I was talking ctDNA. Now CTC has also become very important. This is one of the trial in triple negative breast cancer where they have shown that both ctDNA and CTC after neoadjuvant chemotherapy in early stage triple negative breast cancer is a very important biomarker to identify recurrence-free clinical outcome. If you see the survival of this, if both of them are negative, you have better outcome compared to both of them positive. Whereas if any of them is positive, there is, not as good outcome as both of them negative. So detection of ctDNA and CTC in patients with early triple negative breast cancer after neoadjuvant therapy is becoming now independent biomarker for identifying recurrence. So how we do the CTC, this is the technology which we have developed. Dr. Jayan Kandari has developed this technology. It's a patented technology, has a higher sensitivity compared to what is existing CTC technology, and is affordable compared to the current technologies, what is commonly practiced. So this is another study, very important study, stage 3 colorectal cancer, where they have done this CTC in patients in baseline after 3 months and after 6 months. So what you can see is the CTC number reduced in 3 months, but increase in 6 months. That's what is explaining the longitudinal monitoring is having more impact in order to identify, if there is a possibility of recurrence. This has been shown that, even though like in patients BRAF mutation and CTC number is definitely correlating with progression of these patients. So one of the case in head in CA tongue, where at April this we have done it. This patient, 80-year-old, refused to do surgery and was put on metformin chemotherapy, and continuing complete response was identified based on the CTC. At April 2021, 3 CTCs were identified and see the disease, and May 2021, 1 CTC was identified, and you see how much control is it. And July 2001, you can see there was no CTC and see the clinical response. This is how these ctDNA and CTC can explain you and help you to identify how you can monitor the patients. Another case, CA rectum, which was treated by Dr. Nirmal Rao from Mumbai, T3N2 in March 20, NACT FOLFIRI was 4 cycles given, chemotherapy, radiation therapy, long course, surgery was done, Capox 4 cycles, and then by CT scan, the patient was, there was no sign of a disease, and about to discharge the patient, but somehow he sent for CTC. We found 2 CTCs in 1.5 ml of blood. Based on that, he advised the patients to go for MRI liver, and there were 4 lesions. So if he would have gone home and, after 4 months, patient would have come with the full disease and difficult to treat. And then this was given as
Sir, kindly conclude your talk in 2 minutes, please.
Yeah, just 2 minutes. And then there's how we use in breast cancer longitudinal monitoring. We have done it in ovary patients. To summarize that, the comprehensive profiling can help us to identify, driver mutations, identify intratumoral heterogeneity, find the rationale for combinational therapy, do the longitudinal monitoring, which can help us to identify increasing or decreasing of CTC, ctDNA over a period of time, which can help us to predict recurrence, progression, and minimal molecular residual disease can be identified immediately post surgery. And therefore this ctDNA based and CTC based technology is actually helping us to monitor the response and detect early resistant mechanism. However, we should be very careful about using CT, liquid biopsy or tissue biopsy. It should be carefully determined who should get liquid biopsy, who should get tissue biopsy, and choice should be based on, to identify tumor biology, tumor evolution, tumor heterogeneity. So with this, thank you.
Thank you so much, Dr. Safi, and it was a wonderful presentation. You recommend doing both CTC and ctDNA for all your patients every 3 months time? Is it that you want to say?
Every 3 months, it's always a clinician should take a call, but typically what studies have shown, about 45 days to 3 months should be done. But that can be extended also based on how patient is doing. It could be even after 6 months.
So we have the CTC studies in, I think, breast, colon, and head and neck.
Yeah, head and neck.
So is it validated for all the type of tumor cells, tumor types, or it is validated for only these 3?
What we have done is like breast, colon, head and neck, lung, bladder, prostate. We have done, and apart from that, what additional data has shown in other cancer types as well, from different institutions internationally.
So it is validated for all of the tumor types?
Yes.
Okay, but I find it difficult to incorporate into the clinical practice. So even if I find the resistance, CTC DNA or residual ctDNA after the treatment is over, so guideline doesn't tell what to do next about that.
Yeah. So see, if I take an example of that colorectal cancer, where we have found 4 CTCs, and we have found 2 CTCs, and there was no PET scan. That helped the doctor to take a decision to go for MRI. So this is one way to what can other than CT scan, you go for MRI. Second thing is, if you are going to tell a patient, patient is a stable, asymptomatic, you asking patient come after 6 months, but because of ctDNA or CTC is found, you will ask that come after 2 months. You close the follow-up rather than going 6 months, you reduce it to 1/3 of that. So that, and do again and see, that time you may get, other parameters which can help you to take the decision.
I think one most important clinical scenario where I would like to do CTC or ctDNA is stage 2 colorectal cancers, where we typically think that the patient can be kept on follow-up or he needs the treatment or not. So I think this is one very, very important thing. You did a wonderful talk. Any other questions if we have for Dr. Shafi?
So, Dr. Shafi, hi. So it was a wonderful talk, and it is something which is upcoming. So, collaborating CTC and ctDNA for all these aspects. So, can you tell me So you already explained that it can be used in neoadjuvant adjuvant setting also, and it can be used in a palliative setting also. So which is one indication where a clinician should definitely try to use, and both a combination of CTC and cell-free DNA, or only CTC or only cfDNA. So what is going to be the benefit of using it both together or as a individual test-based assay?
See, colon cancer, particularly stage 2, is a very good indication, which you should definitely test it. Okay. And second thing is, whether you go for CTC or ctDNA, as I shown you the triple negative breast cancer study, they have clearly shown, if both are negative, you have better outcome, whereas if both are positive, you have a worse outcome. But there is a two intermediate curves where one of them is positive, either CTC and CTC, they also have a bad outcome. So this is always, 1 + 1 makes 11, we say always. And this is, I would use the same analogy here. If you use only one, you may get informed. But if you use both, if one may be negative, other, we have recently done one test, it was a colon cancer. And when we did it, what we found is ctDNA positive, CTC negative. After about 40-45 days, we got again a second time point. Now both came positive. And that patient was not willing, he was trying to avoid adjuvant therapy. And now it's very clear the patient should get adjuvant therapy, because there is increase also. There was 0 CTC, now there are 4 CTCs. There was the ctDNA load has increased. We could see the graph clearly, it is increasing. And now it's a clear indication that he should get a adjuvant therapy.
Okay. So one more question. So it's regarding the concordance of imaging-based evaluation and CTC or cfDNA. So probably like if it is a palliative setting where you have started with CTC cfDNA as a monitoring assay, and you have done it for the first instance, which is the baseline, so which showed that there are 3 CTCs which are detected, and 3 months later, when you have given the therapy to the patient, so your CTC says that now there are 5 CTCs, so they are detected, but your scan suggests that either it is a stable disease or there is some response. So means how much is the concordance between the imaging based assays and the CTC based assay, and if there is a discordance, so how to go about it?
So yeah, discordance is there, and I see the discordance is very important here for us. So for example, this ctDNA, CTC and ctDNA detect positive, and then CT scan or PET scan has not found, or it found it's a stable. So this information is more important, because this is what we are looking. We don't want to make sure that, think that, everything is fine. So this becomes very important. I would, ctDNA or CTC and PET scan concordance is fine. Both negative, both positive is fine. But CTC, PET scan and the ctDNA and CTC, discordance is important information, and that's where it has a value. It adds value to the clinician's practice, because you may not be able to take decision, but it is giving you information that, there is something which may not be detected by PET scan, because there is a limitation of PET scan as well.
No, but for a clinician, so he has to make one decision. He cannot make 2 decisions. So whether to go ahead with the CTC report or to go ahead with the imaging report. So
No,
this is what he has to choose.
I would only suggest that, when CTC and ctDNA has come positive, but PET scan is negative, you have to watch closely and possibly repeat the test, in next 45 days or to 2 months, to see if it is increasing, then definitely disease there. If it is decreasing or remaining same, and you can continue monitoring the patient.
No, but what you are suggesting, that is in a adjuvant setting. So where you are monitoring for recurrence of the disease. I'm talking of a palliative setting.
Okay.
Where the patient is on treatment. So you started, so you made up your mind that you are going to monitor the patient on the basis of CTC, cfDNA, and imaging based assay also. Okay. So there is a discordance now. 3 months down the line, the patient is on palliative chemotherapy or supposedly immunotherapy or targeted therapy, and the patient has now a discordant result. So now the clinician has to make a choice whether to go ahead with the same treatment or whether to change on the basis of this.
Yeah. So, for example, let me give the immunotherapy as an example. See, immunotherapy is a bigger problem. What we have is pseudo progression. And if I go with a PET scan and it gives me a pseudo progression, which I don't know, it shows me progression, which is
So I'll give you a clinical scenario. So the patient is on immunotherapy and chemotherapy both together. 3 months, the CTC count has increased and the PET CT is showing a response.
Yeah. See, if you
Or
ask
can I
me,
take this question if you don't mind?
Yes, please, Arvindan.
Yes, sir. Praveen sir, thank you for the question. See, there are two things which are very clear. CTC, ctDNA, both have to yet make their mark in the guidelines.
Okay.
Okay. But we also know that these give us more information beyond the PET scan. Okay. At a lower tumor burden, at a level where PET scan cannot see. So these are both truths. Okay. But a clinician, if there is a discordance, a clinician first has to go by his instinct. Okay. So if you're saying in this case where the PET scan is showing, response, right? But CTC is going the opposite direction. I would still say go ahead with the results of the PET scan. Do what you will do because of the results of the PET scan. But CTC and ctDNA both are, as a monitoring technique, more effective in the longitudinal setting. You will understand their true nature only when you see multiple time points. Sometimes a single time point can be a confounder.
I totally agree.
Right?
So I think there has to be a study like this where you are taking off a patient and you are monitoring the patient. If there is a PET discordance, PET and ctDNA discordance is there. Right. So at one end, you go ahead with the PET CT report, and at the other end, you go ahead with the ctDNA report. I think this is something which is going to give us the answer.
Yes, sir. And sir, discordance is the real reason why we are doing this test. If you see, right? Or else if PET has to answer everything, we don't want this test. Then why do you want this test, right? The discordance is the real value. That 20% of the cases where it is going to say, look, wait, something is wrong, right? And give you a pause for concern, right? I always tell, sir, we would love to say that, CTC, you should go according to CTC or not, but the guidelines are something. More evidence has to come. More data has to, be, given. But these technologies have the scientific merit to use them in the clinical setting to add as a tool for you to understand what is happening. Right? We are also doing many clinical studies. We are also trying to add to the data that is already available. And surely, sir, ctDNA slowly is making its way to the guidelines. CTC also, we feel that, our technology might someday, ensure that, CTC also goes into the guidelines, sir.
Definitely. We all hope so.
And Manish, sir, I think wonderful, think that stage 2 colon cancer is probably the best place to look at, CTC. The dynamic study, at least, the data is very clear from that. And
I think still there is some more time that the CTC and the cell-free DNA would make into the clinic and into the guidelines. So with this, I think I would like to thank Dr. Saifi. Our next speaker is for the day is Dr. Praveen Jain. He is medical oncologist and head at Akash Cancer Institute. He will be speaking on real-world evidence on third-generation oral TKI, that is osimertinib. Dr. Praveen.
So thank you, Dr. Manish. Thank you for giving me this opportunity. I hope my slides are visible and I'm audible too. Are my slides visible?
Yes, sir.
Okay. So the topic given to me is the real world evidence of osimertinib as a standard of care in the management of EGFR mutated non-small cell lung cancer. We already know that osimertinib, it has become a standard of care in EGFR mutated non-small cell lung cancer. But there are some issues pertaining to the phase 3 trials or the randomized control trials, so that whether the representative population was there in the trial or not, because there is only a minute amount of population which is represented in these clinical trials. And for those particular reasons, so the real world evidences that reiterate the finding of the randomized control trial. So we will talk about these real world evidence in terms of osimertinib. So osimertinib, it is an irreversible third generation EGFR TKI, which had demonstrated a clinically meaningful improvement in median PFS. So which was numerically 18.9 months versus 10.2 months with the first generation TKI in the phase 3 randomized FLORA trial. And this was the landmark trial on the basis of which osimertinib was approved in the first line in this particular subset of patients. Recently, the overall survival analysis was also presented, and the median overall survival with osimertinib was 38.6 months versus 31.8 months with the first generation TKI, and it was statistically significant. So this is the only EGFR TKI which has shown the overall survival advantage, which was statistically significant. So this was the final overall survival analysis of FLORA. We already know that the FLORA trial, it was a phase 3 trial, global, multicentric, and it included those patients with EGFR exon 19 deletion or L858R, which are supposed to be the common mutations. And these patients with metastatic non-small cell adenocarcinoma with stable brain metastasis, so they were randomized into osimertinib versus comparator EGFR TKI, which were first generation TKI, either gefitinib or erlotinib. And the final overall survival analysis after 318 death events had occurred. So that was published, and we could see over here. So this was the final PFS analysis, which showed the median PFS of 18.9 months with the osimertinib compared to 10.2 months with the first generation TKI. And we can see over here the subset analysis and almost all the subgroups. So they did better with osimertinib as compared to the first generation TKI. And we can see the hazard ratio over here, and most of the hazard ratios, so they are less than 0.5. So there was at least 50% improvement in progression-free survival in almost all the subsets. So here is the final overall survival analysis. We can see the median overall survival was 38.6 months with the osimertinib and 31.8 months with the EGFR first generation TKI. And more than the median overall survival, we can see over here at 3 years, 54% versus 44% overall survival when osimertinib was compared to the first generation TKI. So the conclusion of the FLORA trial was that there was a significant overall survival advantage with a delta of overall survival was 6.8 months. And it was the first EGFR TKI to show the statistically significant overall survival benefit. And after 3 years, 28% of the patient in osimertinib arm and 9% of the patient in the comparator EGFR TKI arm, so they remained on the first line study. So it presented a favorable and consistent toxicity profile despite having a prolonged exposure of more than 3 years. And we can see over here the durability of the response, which is seen with osimertinib in almost 1/3 of the patient. So on the basis of this trial, so those patients with EGFR mutation positive non-small cell lung cancer, so the osimertinib is the preferred agent and the category 1 agent as compared to the first generation or second generation TKIs, so which are definitely category 1, but the preferred agent is osimertinib. So after the FLORA trial overall survival analysis, so let us talk about the real world evidence of osimertinib, so which is the topic for today evening. So we are going to discuss these three studies. So one is the flower study. So the second is the OssiFact study, and the third is the Mykonos study. So to start with the flower study, so it was a this study was a real world study, and the basis why this study was taken up was that only 2 to 4% of the patient with cancer they receive treatment within the RCT. So it raises the very important issue of representativeness. There are some other issues also, like the poor performance status, those patients with symptomatic brain metastasis, those patients who have medical comorbidities, those patients who belong to the third world countries. So those patients, they were not included in the FLORA trial, and most of the trials also do not include these patients. So the real world data, they try to look at different countries also, and they try to look at the different patient population which were not included in the clinical trial apart from the clinical trial population. So the baseline characteristics of this trial showed that the median age was 68 years. So the brain metastases were present in baseline brain metastases were present in 30%, which was in line with the FLORA data. So coming to the stages at diagnosis, so most of the patients, so they were metastatic disease. So 23% were having a 4A, which was because of the either contralateral pulmonary metastasis or the pleural effusion, and 4B were 71.4% of the patient, and this was again in line with the FLORA data. So coming to the type of baseline type of EGFR mutational status. So most common mutation was exon 19 deletion, and the second most common was L858R. And 2.4% were the rare mutation, which were also included in this trial. So the inclusion criteria of this trial was age more than 18 years, with a histological or cytologically confirmed diagnosis of non-small cell lung cancer, and EGFR mutation positive status, and stage 3B or 4 disease according to the AJCC 8 classification, and eligibility to receive first line treatment with osimertinib. So we can see over here that these inclusion criteria, so these were the basic inclusion criteria where osimertinib becomes the first line treatment approach for these patients, and there were hardly any exclusion criteria. So this is the beauty of the real world studies. So they do not have a very stringent inclusion and exclusion criteria, and most of the patients who are oncologically candidate for the investigator the medicinal product, so they are included in these trials. So the primary endpoint of this trial was so median time to treatment discontinuation. So this again is a very good and pragmatic real world endpoint. So what exactly is median time to treatment discontinuation is that we take the initial time as the time when the therapy started, and the discontinuation or the endpoint is that when the treatment is actually discontinued. Because what we have seen in the targeted therapy era or immunotherapy era is that there are patients who have oligoprogressive disease who are treated with the local treatment, and then the TKI or the immunotherapy is continued for some more time till they have a polyprogression or florid progression. So this median time to treatment discontinuation, it includes that period also, which is post local treatment for oligoprogressive disease. So it gives us a better understanding. So the time duration for which the treatment was continued. And the other primary endpoint was rate of treatment related adverse events. And the third was the rate of dose reduction and temporary or definitive treatment interruptions. The secondary endpoints, so they were median overall survival, median PFS, overall response rate, disease control rate. And this trial also had a look at the diagnostic therapeutic pathway. So this diagnostic therapeutic pathway, so this looked at a very minute things in the patient journey from the diagnosis to the treatment. And these journeys, the endpoints which were taken up during this journey were the time frame between diagnostic biopsy, histologic report, then the proportion of patients who underwent loco-regional treatment, then the type and frequency of rebiopsy performed at progression, and what was found in those rebiopsies. So these were all observed in this clinical trial. So we can see over here that in this trial, those with poor performance status, those with multiple comorbidities, rare EGFR mutations, and active brain metastasis, though they were included. And so the outcome data which was published, so the outcome data was similar to the published trial, which was the FLORA trial. So there was no difference in progression-free survival, time to treatment discontinuation, and overall survival, which were noted in the elderly patients or patients with comorbidity or less common EGFR mutation. So let us look at the Kaplan-Meier curves of few of the categories. So this was the time to treatment discontinuation, and the median TTD was 25.3 months in the overall population. And if we categorize according to those patients who do not have symptom versus those patients who have symptom. So those who do not have did not have symptoms, so the TTD was not reached, and those patients who had symptoms, the median TTD was 18.8 months. A similar kind of analysis with less than 3 metastatic site or more than 3 metastatic site in terms of TTD, and it was significantly better in those patients who had less than 3 metastatic site. So coming to so the survival analysis, one second. So TTD appear to be a more suitable endpoint to evaluate treatment outcome in real world trials. And TTD was longer than the post-progression outcome analysis of FLORA-2 trial. So it was 20.8 months in the FLORA trial. And in this FLOWER study, so it was 25.3 months. So these are the subset analysis which we have already taken up. So those patients who had symptoms at diagnosis, those who had more than equal to 3 metastatic site or brain metastasis, so they had a poor outcome as compared to those who had the counterpart. So looking at the response rates with this trial, with this drug in this trial, so the partial response rate was 73%. The complete response rate was 0%, which was significantly lesser as compared to the FLORA trial. But the response rate was close to 73%, which was in line with the FLORA trial. And only 4% of the patient, they had progressive disease on osimertinib. So coming to the median progression-free survival, similar kind of analysis with the median progression-free survival. So it was 18.9 months in the overall population, and it was significantly better in those who did not have any brain metastasis and who did not have any symptoms. So coming to the response rate as far as the PFS was concerned, again 73% partial response, 23% stable disease. So the real world diagnostic and therapeutic pathway. So they tried to look at the rebiopsy rate with osimertinib in this trial, and they observed that 21 cases out of 44 patients who had progressive disease, they underwent a rebiopsy at progression. And out of these 21 cases, 14 cases, they had tissue rebiopsy, 6 patients had liquid biopsy, and 1 patient had both tissue and liquid biopsy. And out of these 21 patients, so molecular analysis was performed in 13 patients. And out of these 13 patients, so the resistance mechanism, they could elude in 7 patients. So it was more than 50% of the patient who had molecular analysis. So they were able to find out the druggable resistance mechanism, which could have been better to find out so that the patient outcome can be improved. So if we look at the safety data analysis in the real world, so it was in line with the FLORA trial, except the pneumonitis incidences and the venous thromboembolic incidences, which were more in the real world scenario as compared to the FLORA trial. And we will come to it in subsequent slides. So venous thromboembolism, it was the most common endpoint, most common adverse event which was noticed. So 7.9% of the patient had venous thromboembolism, and there were no differences in rate of venous thromboembolism which was reported according to the age, performance status, comorbidity, and tumor load. But I couldn't find any reason why venous thromboembolism was more in the real world situation as compared to the FLORA trial. So coming to the second study, which is the OC-FACT study, again, it was a multi-centric study in EGFR mutated non-small cell lung cancer. And this study investigated the differences in efficacy with patient background and the safety of first-line osimertinib treatment in real-world scenario. So again, coming to the similar kind of inclusion-exclusion criteria, the only inclusion criteria with this trial was EGFR mutated non-small cell lung cancer with osimertinib as the initial treatment. And the exclusion criteria were those patients who were not having any adjuvant therapy. So those who were not receiving osimertinib as second-line treatment, so they were only included. And those patients who were using concurrently other anti-cancer treatments, so they were excluded. So the median, so the baseline characteristic, again, similar kind of findings which we had seen in the FLORA trial. 49%, so the exon 19 deletion was the most common EGFR mutation. The second most common was L858R. If we see the brain metastasis at presentation, so that was close to 31%. And there were 3% patients who had leptomeningeal metastasis, so they were also included in this trial. And the primary endpoint of this trial was, progression-free survival. And the secondary endpoint of these trials were overall survival, time to treatment failure, response rate, objective response rate, and disease control rate. So the PFS events we can see over here. So the median PFS was not reached. So it was so the majority of the data was not there, but the calculated median PFS was 20.5 months, and they could make out that male gender, malignant effusions, liver metastasis, and advanced unresectable cases. So these were the particular categories so which had poor median progression-free survival as compared to the counterparts. So with respect to PD-L1 expression levels, so there was no correlation which was found in median PFS with osimertinib as far as PD-L1 expression levels were concerned. So a similar tabular view of same. So the male patients, malignant effusions, liver metastasis, and stage 2, 3, 4 patients. So they had poor progression-free survival as compared to the counterparts, and the PD-L1 expression did not make any impact on it. So this is a very important slide. So, and it was a very surprising finding which was seen in this trial, that so these are those patients who had discontinued the treatment, and the 219 patients discontinued. And the most common reason for discontinuation was disease progression, which was seen in 44%. But this is something which I want to make a note of. So 25% of the patient out of these 219 patients, so they discontinued treatment because of pneumonitis. And 16%, so they were because of other adverse event. So out of 219 discontinuation, almost 40% of the patient they discontinued because of the adverse events. So this was particularly very surprising that 12.8% of all patients, so they developed pneumonitis, and almost 8% of these patients, they had more than equal to grade 3 pneumonitis. And if we see the QT prolongation, again 4.1% QT prolongation, all grade, and 6 patients had grade 1 to 3 QTC prolongation. So the overall response rate was 76.2%, DCR was 94.1%, median time to treatment, median TTF was 19.1 month, and pneumonitis of all grade happened in 12.8% patient, and fatal pneumonitis happened in 4 patients. So this is the third and the last study, so which is the real world study of patient with EGFR mutated locally advanced or metastatic non-small cell lung cancer. And this study was published in JTO, Journal of Thoracic Oncology. So this study, so this basically looked at 2 new endpoints, so which were the real world time to new treatment or death, and the real world time to treatment discontinuation. So this was the subjects were taken from the Fletitron health database, and these subjects were de-identified first, and the patient level structured data. So they were curated via the technology enabled abstraction. And during this study period, almost 280 US cancer clinic, they were scrolled for the patient population, and the study inclusion criteria were those patients with more than 18 years of age with advanced non-small cell lung cancer with EGFR mutation positive status who had initiated first-line osimertinib. So the diagnosis start date was later to January 1, 2011, and the patient identification was started in April 1st, 2018, and the last patient was enrolled in March 31, 2020, and the we can see over here these were the baseline characteristics, and again similar kind of thing that metastatic side brain metastasis were seen in 33% of the patient, which was in line with the FLORA trial. Again, coming to the type of the EGFR mutation status, so exon 19, it was almost half, which was the most common. L858R was the second most common mutation which were identified. So again, it was in line with the FLORA data. So this was the treatment sequencing chart. So out of 548 patients who were started on first line osimertinib, so 318 patients, so they remained on first line therapy or lost to follow up. So out of those who received second line treatment, out of these remaining 220 patients, so half patient they received second line treatment, and half they either died on the first line treatment or they discontinued first line treatment. And the most common subsequent treatment was either some other EGFR TKI based therapy or immunotherapy. So this was the real world time to new treatment or death, which was 17.9 months. And we can see over here in the multivariate analysis, stage at initial diagnosis of non-small cell lung cancer, smoking status, Charlson comorbidity index, EGFR mutation type, and number of metastatic site more than equal to 4. So these were the factors which significantly correlated with better real world time to treatment, new treatment or death. So coming to the real world time to treatment discontinuation, after 230 events, the median real world time to treatment discontinuation was 17.2 months. And again, similar kind of analysis, multivariate analysis showed that those patients who were smoker, those patients who were having a poor performance status, those patients who had non-EGFR del19 mutation type, those patients who had more than equal to 4 metastatic site, and those patients with liver metastasis, so they did poor as compared to the counterparts. So the take-home message with the real-world scenario is that the study provides real-world insight into the use of first-line osimertinib in patients with advanced EGFR mutated non-small cell cancers. The interim real-world time to treatment, new treatment or death, and real-world time to treatment discontinuation results support the effectiveness of osimertinib in this real-world population, and the longer term outcome will be evaluated in the final analysis. With this, I would like to end the topic. Thank you, organizers. And if there are any questions, I'll be happy to answer those. Thank you. Thank you for
Thank
patiently
you. Thank you, Dr. Praveen, for such a wonderful presentation. So real world evidence is very, very important for different drugs. Don't you feel that the pneumonitis and thromboembolism, they were quite high in these studies? Do you encounter such a problem in your real world, real life with your patients?
So I haven't seen this much amount of pneumonitis, but yes, I have seen pulmonary thromboembolism or venous thromboembolism in 2 or 3 of my patients. But the amount of patients, the amount of like incidences of these two side effects, so which is seen in the real world scenario. So I usually do not see that much of VTE or pneumonitis in the real world as far as my patients are concerned.
So I also concur with you. I also don't find so many VTs or pneumonitis with this drug. I think whether the drug is safe to use.
So, but the only thing is, yes, we should definitely monitor the patient for the VTE incidences, and we should be very, very suspicious that if a patient is complaining of a new onset peripheral edema, or if the patient is complaining of breathlessness, or the patient is complaining of some palpitations, and as such also, what I do is that every 12 weekly I get a 2D echocardiography of the patient and the ECG of the patient to find out any ejection fraction decrease or any cardiac side effects.
So thank you so much. And can I share my screen? Is my screen visible?
Yes, sir.
Okay, thank you so much, Dr. Praveen. And the next topic I will be taking upon, and it is the safety of EGFR TKI, which one to choose. So we have plenty of options in the form of EGFR TKI, first generation, second generation, and third generation. Let's see how these TKIs fare against each other and which should be the TKI of choice. So this is a basic slide of staging system of NSCLC, and here we are talking about stage 4 disease, that is M1, A, B, and C. So once the patient comes to us, these are all the diagnostic workup which we do, and the adequate tissue for histology is must. Sometimes if not available, then liquid biopsy is another option for our patients, as we discussed by Dr. Shafi. So all the patients with adenocarcinoma should be tested for oncogenic drivers. Next generation sequencing may be used, must be used, in fact, rather than single gene testing, because it saves tissue and time also. And rebiopsy at the time of progression if the patient was on earlier first generation or second generation oral TKI. So currently, the treatment is driven by the molecular testing. If we find a targeted therapy available for our patient, then the targeted treatment is the way to go. If you don't find any targeted molecular aberration available, then the treatment is obviously depending upon the PD-L1 expression. If the PD-L1 expression is high, then single agent immunotherapy can be used. Else, the combination of immunotherapy or chemotherapy can be used. If you see the survival difference by the chemotherapy and targeted therapy is 8 to 12 months for chemotherapy and 38 months for osimertinib. So this is really a drug which has made a dent on the disease progression for our patients. And these are different kind of mutations which we find in the adenocarcinoma patients, which include EGFR, ALK, ROS, MET, BRAF, NTRK1, PIK3, and MEK. So we will be talking about the EGFR sensing mutation, and in particular, we will be discussing second generation and third generation oral TKI in this slides. So EGFR mutations, they occur in the cluster at exon 18 through 21 in NSCLC. 1.5% patient, they have point mutation in G719X. Exon 19 deletions, they are found in 46% patient. Exon 20, T790M and other mutations in 4.1% patient. And exon 21 mutations, they're found in 37.5% patient. So this has basically EGFR protein has two domains, extracellular and intracellular domain. Intracellular domain has a tyrosine kinase receptor binding domain, the mutation of which leads to the constitutional activation of the downstream pathway. So EGFR mutation is seen in approximately 50% of the Asian patients and 10 to 20% of the Caucasian. And in our own practice in India, we find it to be around 25 to 30%. Most common is exon 19 deletion, followed by LAT58R mutation in exon 21. And for patients with advanced NSCLC harboring exon 19 or LAT58R mutations, EGFR TKI should be used as the first line of the treatment. And this is the comprehensive clinical trial program for EGFR TKI in NSCLC, which evolved after the important molecular discoveries of EGFR mutation in early 2000. And in 1993, the development of EGFR targeted therapies began. 2004, discovery of somatic mutation in TK domain of EGFR in patients with NSCLC are associated with response to gefitinib. 2005, discovery of EGFR T790M mutation. And similarly, then the multiple studies came, first generation oral TKI, second generation oral TKI, then third generation oral TKI, that's osimertinib. So various studies are IPASS trial for gefitinib, Lux-Lung trial for afatinib, then Archer study for dacomitinib, and then the Flora trial for osimertinib. So Flora trial is very, very important because osimertinib has shown CNS activity as well. So what are the considerations when we choose first line treatment? Number one is safety and number two is efficacy. So this is a cross trial comparison, but still we can gather some information out of this. If you are using afatinib versus gefitinib, then the separation of curves start at 12 months. If you are using dacomitinib versus gefitinib, the separation of curve, they start at around 6 months. But if you see the Flora trial, that is osimertinib versus the standard of care oral TKI, there is immediate separation of the curve. And it is important to remember that 19% of the patients, they had stable brain metastasis, which were included in Flora trial. So it has got early and sustained survival benefit, as shown by the clear separation of the curve within 3 months and maintained throughout the follow-up. These are different head-to-head studies which shows second and third generation EGFR TKI provide significantly longer PFS versus first generation EGFR TKI. So CTONG study, erlotinib versus gefitinib, you get around 13 months of PFS versus 10.4 months. Similarly, for afatinib, around 11 months of PFS versus 10.9 months in Lux-Lung 7. In Archer 1050, dacomitinib had PFS of 14.7 months versus 9.2 months for first generation oral TKI. But for osimertinib, you have the highest PFS here in the Flora 2 trial. It is 18.9 months of PFS versus 10.2 months of PFS in standard of care oral TKI. So PFS is a direct measure of the drug benefit, and the immediate separation of PFS curves in Flora study, it provides the unprecedented improvement in PFS at 18.9 months versus first generation oral TKI. So the most efficacious drug is osimertinib. Let's come on to the safety analysis of various drugs which are available to us. First generation gefitinib, second generation afatinib, and dacomitinib in third generation osimertinib. So the osimertinib is designed to selectively target both EGFR sensing and EGFR T790M mutation resistance mechanism while sparing the wild type EGFR. First generation is reversible binding, second generation is irreversible binding, and third generation is also irreversible binding with significant ability to cross blood-brain barrier, which is not present in first generation and second generation oral TKI. This graph shows comparative selectivity of first generation, second generation, and third generation TKI towards wild type EGFR. So on the right, you can see that the osimertinib is least sensitive for wild type EGFR TKI. It doesn't affect wild type EGFR, while it is most sensitive for T790M mutation, and hence there is less toxicity in EGFR TKI such as osimertinib as compared to the other molecule like dacomitinib and afatinib and first generation oral TKI. So these are the frequency and severity of selected clinically relevant all causality adverse events varies between the EGFR TKI. So gefitinib, main issues which we find are elevated LFTs in ILD events. In afatinib, diarrhea is a concern and stomatitis is a concern. Similarly, in dacomitinib, you can see that 87% of the patient, they will have some kind of diarrhea, and 9% patient, they will have grade 3 diarrhea. Stomatitis is also significant, that is 44%. And for osimertinib in the FLORA trial, you can see that the most common side effect was ILD. The frequency and severity of the selected clinically relevant all causality adverse event varies between EGFR TKI. Second generation EGFR TKI leads to higher frequency of adverse events that are associated with pan inhibition of herbs such as rash and diarrhea than first generation and third generation TKI. While the EGFR TKI induced rash, diarrhea are usually mild to moderate in severity, but their frequency as grade 3 event can vary amongst EGFR TKI. It is higher amongst the patients treated with afatinib and dacomitinib. In case of rash, in erlotinib and gefitinib, the frequency of grade 3 rash appears to be higher amongst the patients treated with erlotinib, probably because of the difference in the pharmacological properties between the two drugs. And the reason for the liver dysfunction being more frequent in patients treated with gefitinib, basically it remains unclear. Coming on to the safety data of the dacomitinib in the Archer 1050, you can see that the diarrhea was present in 87% patients, paronychia 61% patients, stomatitis 44% patient, decreased appetite 31% patient, dry skin in 27% patient. While if you compare side by side the FLORA trial, all cause adverse events of any grade occurring in more than 10% of the patient receiving osimertinib in FLORA trial, they are listed here, and diarrhea was in 58% patients, paronychia 35% patients, stomatitis 29% patients, rash 56% patients. So adverse events of any grade, they were much higher in dacomitinib in Archer 1050 as compared to the osimertinib in the FLORA trial. And this is the tolerability profile of EGFR TKI. You see in Archer and afatinib trial, that is LUX-LUNG 3 trial, adverse events of more than grade 3, they were 49% in afatinib, 63% in dacomitinib, while in FLORA trial, treatment-related adverse events which were more than grade 3 were in 18% of the patients. So quite a less number of patients had grade 3 adverse events as compared to the afatinib in LUX-LUNG 3 trial and dacomitinib in Archer 1050 trial. So second generation EGFR TKI have unfavorable toxicity profile, grade 3 and above adverse events are much higher in dacomitinib and afatinib as compared to the osimertinib. Coming on to the grade 3, 4, and 5 adverse events. You can see the grade 3 diarrhea in the FLORA trial was just seen in 2.2% patient and fatigue in 1.4% patient. While in dacomitinib arm, in the Archer 1050, the diarrhea was in 8% patient. Grade 3 diarrhea was in 8% patient, and grade 5 diarrhea was in 1% patient. So grade 3-4 adverse events with dacomitinib were reported in 63% patient of the Archer 1050. Coming on to the dose reductions and any adverse event leading to the death. So dose reductions were needed in 66% patients in dacomitinib because of the adverse event, while just 2.9% patient had to be dose reduced in the osimertinib in the FLORA trial. And any adverse event leading to the death was 10% in dacomitinib trial, and it was 2% in the osimertinib. So there is significant difference in the dose reductions in the CTS adverse events and adverse events leading to the death in Archer 1050 and FLORA trial. So the patient treated with osimertinib reported fewer higher adverse events as compared to the standard of care EGFR TKI, that is erlotinib and gefitinib. Patients receiving second generation EGFR TKI are more likely to require dose reductions due to adverse events. And this is dependent on the adverse event duration and severity. The dose modification of the second generation oral TKI may be necessary to improve tolerability. In Lux-Lung trial, adverse events leading to the dose reduction were more frequent in the patient receiving afatinib, that is 52% versus 1.9%. Archer 1050, 66% versus 8% in the gefitinib, while in FLORA it was 4% and 5% respectively in the osimertinib and standard of care oral TKI. So Lux-Lung 7 dose reductions were more frequent in afatinib compared to the gefitinib. Archer 1050 dose reduction was 66%. 38% of the patients receiving dacomitinib had dose reduced to 30 milligram, and 27% had dose reduced to 15 milligram. The median time to first dose reduction for dacomitinib was 2.8 months, and these data suggest that dacomitinib is often intolerable at the starting dose of 45 milligram per day. So this we have already discussed. So post-hoc analysis data. So we will be discussing upon the quality of life issues. Lux-Lung 7 trial compared afatinib to gefitinib and showed that there was similar improvement in the quality of life in both the treatment. Archer 1050 showed that the overall quality of life improved significantly from baseline in the patients treated with gefitinib rather than dacomitinib. In FLORA, the osimertinib showed significant consistent trend towards better improvement across scores compared with the gefitinib. However, none of these scores reached clinical significance and no conclusion can be drawn. These are the quality of life data in Archer 1050 and FLORA. So global quality of life significantly worsened in the dacomitinib group versus gefitinib group. And remember, one of the treatment goal in the metastatic setting is to improve quality of life of the patient. Second generation EGFR TKI worsen the quality of life, and which is clinically unacceptable. These are various studies for quality of life measures in gefitinib and erlotinib. Coming on to the management of the adverse events, that is acneiform rash and diarrhea. So incidence of skin and GI toxicity with EGFR TKI in NSCLC. Acneiform rash, dry skin, it is seen with gefitinib in 66% patient, erlotinib 73% patient, afatinib 89% patient, and osimertinib 34% patient. Pruritus 19% patient in gefitinib, 18% patient in afatinib, and 13% patient osimertinib. Diarrhea 46% patient gefitinib, 95% patient afatinib, and 41% patient in the osimertinib. Stomatitis 17%, 72% patient in afatinib, and 15% patient in the osimertinib. So these are various grades of papulopustular acneiform rashes that can happen with EGFR TKI. Grade 1, BSA less than 10%. If it is spread in 10 to 30%, then it is grade 2. Grade 3 is 30%, more than 30%, and erosions, vesicles, desquamation may be present. And grade 4, BSA is more than BS involving more than 30% BSA, and blistering, erosions, ulcerations, and epidermal denudation may be present. So these are the management guidelines for skin rash. If it is grade 1, continue oral TKI and apply anti-inflammatory antibiotics such as clindamycin 1% lotion. Topical corticosteroid may not be needed. If itching is present, then it can be used. Similarly, grade 2 rash, use oral anti-inflammatory antibiotic at least for 6 weeks. Doxycycline 100 mg VD or minocycline 100 mg VD can be used. Clindamycin 1% lotion. Grade 3, anti-staphylococcal antibiotics such as cloxacillin, cefixaline for 7 days. Consider for a skin swab and a culture. And potassium permanganate washes. The drug can be resumed to the previous reduced dose if the patient recovers to the grade 2, less than grade 2 rash. And if it is grade 4 rash, interrupt TKI, refer to the dermatologist, and patient may need admission in the skin or burn wound. Osimertinib for any adverse grade 3 event, withhold treatment for up to 3 weeks. If the reaction improves to grade 0 to 2 within 3 weeks, then resume treatment at 80 milligram. If does not improve to grade 0 to 2 within 3 weeks, and permanently discontinue the treatment. For diarrhea, grade 1, increase of frequency is 2 to less than 4 per day is grade 1. Grade 2 is 4 to 6. Grade 3 is 7 or more stools per day, and limiting the self-care activities of daily living. Grade 4 is life-threatening diarrhea and urgent intervention is needed. Grade 5 is death. So these are the management strategies for TKI-induced diarrhea. Most of the cases of uncomplicated grade 1 to 2 diarrhea can be managed effectively with antidiarrheal agents such as loperamide or diphenhydroxylate atropine or resveratrol. For grade 3 or medically complicated diarrhea, more aggressive management is needed. Interruption of the treatment is needed, and the reinitiation can be done at reduced dose. With medically complicated diarrhea, moderate to severe cramping, patient needs further evaluation and treatment in the form of antibiotics and hydration, etc. So these are diarrhea management recommendations in the prescribing information for oral TKI, which are present in all of them. So grade 1, 4 milligram loperamide immediately after symptom begin, and 2 milligram after each loose stool until there are no bowel movements for 12 hours. 16 milligram a day is the maximum dose. Grade 2, similarly, it should be done. Apart from that, the assessment for the hydration and electrolyte imbalances should be done. For grade 3, hospitalization is needed. Continual loperamide treatment and aggressive IV fluids. For any adverse event more than grade 3, so we have already discussed this. So coming on to the summary, second generation EGFR TKI are burdened by toxicity profile. Adverse events leading to dose reductions are much more in Archer trial versus Flora. Grade 3 or above adverse events are reported in more than 63% patients. Dacomitinib deteriorates the quality of life of the patients. On the other hand, we have approved third generation osimertinib, which is far more superior toxicity profile and clinical profile, be it efficacy, tolerability, CNS activity, and quality of life. So these are NCCN guidelines, which gives a preferred status for osimertinib and category 1 for osimertinib, although all are category 1, but preferred status has been given for osimertinib. So the Flora trial for EGFR positive NSCLC must be taken as a reference in the era of precision medicine, showing a statistical and clinical significant improvement without any concerns related to the toxicity profile and very high activity of brain metastasis, reducing the comfortless role of whole brain palliative radiotherapy. On the other hand, second generation EGFR TKI are burdened with the toxicity, which we have already discussed. Archer 1050 also excluded the patient with brain metastasis, failing to provide fundamental information of the drug in the evaluation process. So these are the prescribing information for osimertinib. Any questions, I am happy to take. So if there are no further questions, we can invite our next speaker, Dr. Abhishek Yadav. He is consultant and head in Yashoda Super Specialty Hospital, medical oncologist. He'll be speaking on the recent update from WCLC 2023, in particular FLORA trial. Dr. Abhishek, over to you.
I hope I am visible and I am audible as well.
Yes, Dr. Abhishek, welcome.
Thank you, Dr. Manish. Thank you, organizers, for this opportunity. And a very good evening to Dr. Praveen. So, the topic that has been given to me is a very interesting trial, which has, are my slides audible? Are my slides visible?
Yes, Dr. Abhishek.
Yes, sir, you can make it full screen.
Yeah.
Perfect, sir.
So, this important, as we have seen that osimertinib is all around in the paradigm of NSCLC, especially in the EGFR mutant patients, from adjuvant setting to the metastatic setting and to the new adjuvant setting, as well as with the ongoing trials. And we have seen that we can probably divide the EGFR mutation era into three types: the pre-EGFR mutation TKIs, and then the EGFR mutation, then the EGFR TKIs, and then we got the osimertinib. So osimertinib was a landmark in the management of EGFR mutated advanced NSCLC patients, and with the trials ongoing in all the settings, we hope that this molecule holds even a better prospect and even a better future in these patients and in offering them a better future. So the trial that I'll be discussing today is with osimertinib with or without platinum-based chemotherapy as first-line treatment in patients with EGFR mutated NSCLC, that is FLORA2. So just to have a background, most of it has been discussed by Dr. Manish and Dr. Praveen. EGFR TKIs are standard of care first-line treatment of EGFR advanced NSCLC. However, most of the patients will progress following the treatment, as we have seen that whatever treatment we give, after a certain time, the resistance comes and the disease progresses. And the clinical factors associated with poor prognosis are the CNS metastasis and L858R mutation. So osimertinib is a third generation CNS active EGFR TKI and is the preferred treatment, first line treatment for EGFR mutated NSCLC based on superior PFS and OS benefit with osimertinib versus comparator EGFR TKIs in the FLORA trial. So clinical data on first generation EGFR TKIs combined with chemotherapy have suggested enhanced efficacy. Osimertinib plus platinum pemetrexed recently showed encouraging activity in the phase 2 OPAL study in Japanese patients with untreated EGFR mutated advanced NSCLC with an overall response rate of 90.9%. Median PFS was 31 months. However, this combination has not been evaluated in a RCT. So, the global open label randomized FLORA2 study assesses the efficacy and safety of osimertinib
plus platinum pemetrexed versus osimertinib monotherapy as first-line treatment for EGFR mutated advanced NSCLC. So here is the FLORA2 phase 3 study design. So the important thing was there was a safety run period with a subject of 30 patients, which was published in ESMO 2021. And after this safety run period, the patients were enrolled. Patients with untreated locally advanced metastatic EGFR mutated SCLC were included, and the key inclusion criteria were age more than or equal to 18 years. In Japan, it was more than or equal to 20 years. Pathologically confirmed non-squamous NSCLC with exon 19 deletion, L858R mutant, WHO PS 0 or 1, no prior systemic therapy for advanced NSCLC, stable CNS metastasis were allowed in the study. And there must have been a baseline brain scan at the enrollment. So the stratification was done by race, that is Chinese, Asian, non-Chinese Asian, or non-Asian, and EGFR mutation local or central test, WHO PS 0 or 1. So total number of 557 patients were taken, and they were randomized between osimertinib 80 milligram per day plus pemetrexed 50 milligram per meter square with carboplatin UOC5 or cisplatin 75 milligram per meter square for 4 cycles, followed by maintenance osimertinib plus pemetrexate. So this was the trial arm with the comparator arm of just osimertinib 80 milligram per day. So follow-up was done by RECIST 1.1 assessment at 6 and 12 weeks. Then every 12 weeks until RECIST 1.1 defined radiological disease progression or other withdrawal criteria were met. So the primary endpoint for the study was PFS. As we have already know that PFS is almost always the primary endpoint when we undergo a trial with such ambitious results or such ambitious targets. Sensitivity analysis was done by PFS by BICR assessment per RECIST 1.1. Secondary endpoints were overall survival, overall response rate, duration of response, disease control rate, and quality of life index, and safety. Adverse events were assessed by CTCAE version 5. So this is how patients were randomized. Total 557 patients. Patients dosed total were 551. Those who didn't receive treatment or had some problem because of which they were ruled out from the treatment was 6. And 276 patients were assigned to the osimertinib plus chemotherapy arm, and 275 patients were assigned to the osimertinib single agent arm. And ongoing treatment at data cutoff were osimertinib 154 and pemetrexed 68%, and at in the osimertinib arm it was 123, that is 45%. So few patients discontinued the treatment. So the patients who discontinued treatment, out of them osimertinib were the 122, that is 44%. Those who discontinued platinum were the 23%, and those who continued pemetrexed was 75%. And those who discontinued osimertinib was 55%, that is 152 patients. So disease progression and adverse events were the most common reasons for discontinuation of any study treatment. So these are the baseline characteristics of the patients, and we can see that in both arms, the patients were very well matched. So male is to female, in terms of male is to female ratio, in terms of age, in terms of the race, whether Chinese Asian, non-Chinese Asian, non-Asian, WHO PS 0 or 1, smoking status, never, current or former, histology, whether it was an adenocarcinoma only, whether adenosquamous or any other, EGFR mutation at randomization, that is exon 19 deletion or L858R, we can see that there is very well matched population 61/38 versus 60/38, locally advanced or metastatic, extrathoracic metastasis, CNS metastasis also very well matched. So this was a very important point in the study because osimertinib is known to have a very good control in the CNS. So 42 patients in the osimertinib plus chemotherapy arm, and in the osimertinib monotherapy arm, there were 40 patients. And in terms also in the terms of baseline tumor size, mean, median in the size of millimeter. So this is the progression-free survival curve as per investigator. So median PFS was improved by 8.8 months with osimertinib plus chemotherapy arm versus the monotherapy arm. So osimertinib plus chemotherapy arm demonstrated a median PFS of 25.5 months versus the osimertinib monotherapy had a PFS of 16.7 months with a very, very significant hazard ratio of 0.62 and a p-value of less than 0.0001. So the median follow-up for PFS was osimertinib in chemotherapy arm, it was 19.5 months. And in the osimertinib monotherapy arm, it was 16.6 months. So we can see that even at the end of 33 months, the curves are very well separated. So this is the progression-free survival as per blinded independent central review. So median PFS in it, median PFS was improved by 9.5 months. Now PICR is a much better data than the investigator review, because in this the investigator is blinded and it is independent central review. So if we have to consider amongst the two, I would prefer the BICR data more, that it is the PFS is improved by 9.5 months with the chemotherapy plus osimertinib arm versus the osimertinib monotherapy. And even in this curve, you can very well see that the curves are very well separated at the end of 33 months. The separation starts from very early, right? From the 3 months, we can see that the curve starts separating. And as the time progresses, the separation goes on and is very well maintained during the duration of time. So this is a forest plot which shows PFS per investigated across the subgroups. So in terms of all patients, in terms of sex, in terms of race, in terms of EGFR mutation test method, whatever the mutation test method was done, whether it was a RT-PCR, whether it was a next generation sequencing, what was the age at screening, whether the patient had a smoking history or not, whether the patient had a EGFR mutation or which type of mutation he had, whether it is exon 19 or it is exon 21, whether the patient's performance status is 0 or 1, and whether the patient has CNS metastasis or not. In all kind of subsets, we can see that the forest curve very well shows the benefit towards osimertinib plus pemetrexed plus platinum arm. So this is the curve which shows progression-free survival in patients with CNS metastasis at baseline. So we already know that only the patients who had stable CNS metastasis were included in the trial. not those who had symptomatic CNS metastasis or who had a unstable clinical condition due to CNS metastasis. So with CNS metastasis, the median PFS with osimertinib plus platinum pemetrexate arm was 24.9 months, whereas with osimertinib monotherapy, it was 13.8 months, with a very significant hazard ratio of 0.4 months. And we can very well see the curves started separating early and they were maintained till a long duration of follow-up. In the patients who didn't have CNS metastasis, we can say that the benefit still existed. That is, the median PFS in osimertinib plus platinum and pemetrexate arm was 27.6 months, and in the osimertinib monotherapy, it was 21 months, with a hazard ratio of 0.71. So in both the subsets, it clearly showed a benefit, but especially in those who had CNS metastasis, the performance of this combination was outstanding. So this is PFS per investigator by EGFR mutation type. So the patients were also randomized according to the type of EGFR mutation, and they studied each type of EGFR mutation independently, and then they saw what is the progression-free survival depending upon the EGFR mutation type at baseline. So in exon 19 deletion, osimertinib plus chemotherapy arm had a PFS of 27.9 months, and the osimertinib monotherapy had a PFS of 19.4 months, that is median PFS, with a hazard ratio of 0.6. In the L858R mutation, that is exon 21, osimertinib plus chemotherapy arm had a median PFS of 24.7 months, and the osimertinib monotherapy had a PFS of 13.9 months. So as we all know that L858R is a more problematic mutation in which we see a lesser PFS and lesser OS. So we have seen almost an equivalent hazard ratio in both type of subsets. So this concludes that no matter what kind of EGFR mutation we have, whether exon 19 deletion we have or whether we have exon 25 L858R, so this combination works equally well in both of them. So as we all know that FLORA2 has not achieved the median OS, but this is still the interim analysis of PFS2 and interim analysis of overall survival. We can see that second progression-free survival is significantly better in the osimertinib plus chemotherapy arm versus the osimertinib monotherapy arm, and the curves stay separated till 30 months, though they catch up after that. And even in the overall survival, we can see that there is benefit in the osimertinib plus chemotherapy arm versus the osimertinib monotherapy. So hazard ratios have been respectively 0.7 and 0.9. So PFS2 and OS were immature at this interim analysis, 34% and 27% data maturity respectively. At DCO 57 out of 123 patients, that is 46% in the osimertinib plus chemotherapy arm, and 91 out of 151 patients, that is 60% in the osimertinib arm monotherapy, received any subsequent cancer treatment. And in both arms, cytotoxic chemotherapy was the most common subsequent anti-cancer treatment. 33% and 54% in the combination and monotherapy arms, respectively. So this is another very important aspect, that is the safety summary. So median total duration of osimertinib exposure was 22.3 months, ranging from 0.1 to 33.8 months in the osimertinib plus platinum arm, and 19.3 months, ranging from 0.1 to 33.8 months in the osimertinib monotherapy arm. In the combination arm, patients received a median 12 cycles of pemetrexed, ranging from 1 to 48, and 211 patients, that is 76%, completed 4 cycles of platinum-based chemotherapy. So it also surrogates us that if 76% patients were able to complete the combination therapy, it is a very good tolerance to the combination therapy. Now, if we see the adverse events in the osimertinib plus chemotherapy arm, there were almost all the patients who received some kind of adverse event, that is 276 out of 76. And in the osimertinib monotherapy arm, 97% patients received some kind of adverse event. So any adverse event more than or equal to grade 3 was 176, that is 64%, as expected in the osimertinib plus chemotherapy arm, whereas it was just 75, that is 27% in the osimertinib arm. And any adverse event leading to death, it was 7% in the osimertinib plus chemotherapy arm, whereas it was 3% in the osimertinib monotherapy arm. And we can also see that serious adverse events were almost double in the osimertinib plus chemotherapy arm versus the osimertinib alone arm. So if we see that any adverse event leading to discontinuation, it was very high in the osimertinib plus chemotherapy arm, that is 138, whereas it was just 17, that is 6% in the osimertinib monotherapy arm.
Sir, kindly conclude your talking points, please.
So any adverse event possibly casually related to treatment were 97% in the osimertinib plus chemotherapy arm, whereas it was 88% in the osimertinib monotherapy arm. So these are the what kind of common adverse events that we experienced in more than 15% of patients. So the most common in the osimertinib plus chemotherapy arm was anemia, followed by diarrhea, nausea, neutropenia, thrombocytopenia, decreased appetite, constipation, rash, fatigue, vomiting, stomatitis, paronychia, COVID-19, I cannot say because this is a very ambiguous thing. Though when the trial was going on, the COVID-19 was ongoing. The transaminase increase, dry skin, AST increase, blood creatinine increase, WBC count decrease, and the peripheral edema. And in the osimertinib monotherapy arm, we can see that anemia was very, very less in comparison to the chemotherapy arm. And the most common side effect was diarrhea, which was experienced by 40. And the next most common was paronychia, followed by dry skin, followed by rash. As we all know, they are all EGFR TKIs, and we know that the skin reactions and the skin adverse events are more common with them. So of most common adverse events occurring in more than 15% patients in either arm, all grade 4 adverse events in the osimertinib plus chemotherapy arm were hematological toxicities known to be associated with chemotherapy. There were no common grade 4 adverse events in the monotherapy arm. So ILD was reported in 9 patients, that is 3% in the osimertinib plus pemetrexed plus platinum arm, and in 10 patients, that is 4% in the osimertinib monotherapy arms. So we cannot see a much difference in the incidence of ILD as an adverse event in the both arms. So if we derive a conclusion, osimertinib in combination with platinum pemetrexate has demonstrated a statistically significant and meaningful improvement in PFS over osimertinib monotherapy in patients with EGFR mutated advanced NSCLC with an overall hazard ratio of 0.62. Investigator assessed median PFS was 25.5 versus 16.7 months with an improvement of 8.8 months. But if we see the BICR assessed median PFS, the PFS was even better. That is 29.4 versus 19.9 months. That is an improvement of 9.5 months. So PFS benefits were consistent across all predefined subgroups. PFS2 and OS data were immature at this interim analysis. The safety profiles, as expected for each treatment, were manageable with standard medical practice. Further ongoing analysis include CNS BICR response and progression, patient-reported outcomes, post-progression endpoints, and ctDNA analysis. That is the resistant mechanisms and the CT dynamics. So I feel that the key behind the success of this trial was if we include chemotherapy with the osimertinib, it delays the resistance mechanisms. It delays the time the tumor takes to develop. The tumor takes to develop a resistance against osimertinib, and which gives us an opportunity to maximize the survival and the progression-free survival in these patients. And it will be very interesting to see how the data of overall survival and the secondary PFS matures in this trial, and how this molecule does in the neoadjuvant and in the other settings. So to conclude, osimertinib plus platinum plus pemetrexate offers a new first-line treatment option for patients with EGFR mutated advanced NSCLC, but with a little bit of increased side effects. But then it is still worth if patient can tolerate it and if we have a patient with good performance status. Thank you.
Dr. Abhishek, thank you so much for the wonderful update from WCLC. So looking at the data and the adverse event, which I was looking at, there were quite a lot. But the PFS of around 9.5 months difference is also very, very significant. So how do you fare this data, and do you think it is going to be practice changing, or you're going to make the practice change from the tomorrow morning when you're looking into this data?
Manish, this is definitely a practice changing data, because if we see that this is a subset which we can offer the maximum lifetime, or whom we can offer the maximum benefit. So as far as the side effect profile is concerned, it is very erratic. Some people do very well. Some people don't even tolerate a single agent chemotherapy very well. But with a BICR observed PFS of 9.5 months in a metastatic setting, that too with CNS metastasis, I think this is a wonderful data, and this should be practice changing for all of us.
But I am little much worried about the adverse events. You can see that grade 3 adverse events, they were seen in more than 60% patient. Then there were treatment discontinuation in 45% patient. So do you think that it is going to be a problematic thing?
Yeah, it is going to be a bit problematic in the patients who don't have a very good performance status.
Yes, I think.
But if we see the inclusion criteria of this trial, the patients, those who were included, were of performance status 0 or 1.
So I think patient selection would be a patient selection
will be very important. Patient selection will be very important because in India, you don't get patients with a PS performance status of 0 very frequently, as you and me and Dr. Praveen would agree that this is not a subset that we very frequently meet with. So most of the patients that we encounter with are in performance status 2 or 1, very rarely we see a patient with performance status of 0. So depending upon the tolerability and depending upon the patient subset, I think we have to make a wise decision. But if we definitely get a patient who has a very good performance status, whom we think he can do very well, a very stable patient in terms of CNS meds, a patient who is not diabetic, who is not having any other comorbidities, then I think this combination is worth trying.
And I think we'll also like to see the overall survival data as well.
Absolutely.
think
That is what I'm telling you. That it will be very interesting to see how the overall survival and after the immunotherapy, we have become so much interested in the secondary PFS thing, because in my practice I have seen the secondary PFS is a very, very important endpoint in terms of lung, in terms of head and neck, in terms of many cancers. The secondary PFS has become a very, very important thing. So I am equally interested in OS and I am equally interested in the secondary PFS. Let's see how the data matures with time.
So Abhishek, was there any note of the resistance mechanisms? So what they could find out?
Pardon, sir? I couldn't hear you.
So on was there any documentation of resistance mechanism to this thing? So means were they varied or were they different from the flora data or they are similar?
Sir, I don't think they have mentioned this thing in the trial, right? Till now. The resistance, the mechanism of resistance.
I think we have to wait for data to get matured because the thing is that
The data is yet to mature. That's what I'm telling you. Right
yes,
now,
yes.
till now, it has not matured. How the
So
things,
because
how the things at the molecular level have changed.
if we take the comparator arm as osimertinib, so there is a delta of 6 or 7 months, and this delta of 6 or 7 months, like the sequential osimertinib followed by chemotherapy, so you might get a similar kind of like if you see the PFS2 of osimertinib monotherapy arm where the chemotherapy is given as a second line therapy, so probably you will be somewhere reaching around 25-26 months. So I think it is more important for us to have the data matured, and we look at the overall survival advantage or the PFS2, which you rightly said that it is a very robust endpoint at this point of time for us.
Absolutely, sir. And moreover, with the kind of safety profile, that Indian patients are not that strong, they are not that well nourished, we don't get the patients in a very good performance status in India. So trying this combination will be a little bit tricky in our patients, in our subset of patients. But if we get such a kind of patient who has a very good performance status, then probably we can try this out. But then definitely we have to wait for the data to mature. And especially, I think both are equally interesting, the OS as well as the secondary PFS.
And how many percentage of the patients, so they took pemetrexed maintenance in this trial?
Yeah. So I think this is mentioned in the, I think somebody else is sharing. I cannot share my slides.
I think you mentioned it to be, I think 10 to 12 of a median pemetrexed.
No, they said that a good significant number of patients discontinued with the pemetrexate.
Dr.
In the
Praveen, I would
maintenance.
still not use this combination from tomorrow morning because the toxicity is very, very high. And
Yes, absolutely.
and until and unless you can very well sequence the chemotherapy as well after osimertinib. So
But
as you,
Manish, see, we all have used now chemotherapy plus TKI combination in our clinical practice. So I also have used in, I think, 2 or 3 of my patients, and fortunately I haven't come across a very bad toxicity profile. So I haven't seen that. So I
but
think
you see the trial data, 63% patient they had grade 3 toxicity, and you rightly said that we can also sequence. So PFS2 in the FLORA trial was somewhere around 6-7 months. So 18.4 months of osimertinib in first line, and then 6-7 months of PFS in the second line. I think the sequence can also be done. And why to expose the patient to the chemotherapy toxicity upfront when the sequencing the osimertinib after chemotherapy is giving you the same PFS. I think I would definitely like to wait for overall survival results before I go for this data.
No, I have 2-3 patients who have progressed on osimertinib and I have started on chemotherapy. Unfortunately, none of them did well.
Okay.
So probably they all progressed within 4 to 5 months. This I must admit, and probably that is the only thing that might push us towards or push me towards using this combination. But then again, if you, as I have already discussed with the slides, the toxicity profile is drastically different, and a cancer treatment is not just about giving more life; it is about quality of life as well. So if you increase the life of somebody by 6-7 months, but by making him suffer for 3-4 years with the toxicity, I don't think it is worth it. So probably this is the only thing that will irk me in my mind in using this combination in our population. But yes, if the data of secondary PFS and OS comes out to be very robust, then probably this combination will become a favorite amongst us.
Thank you so much, Dr. Abhishek, and thank you so much, Dr. Praveen, for coming in and having your comments. Thank you all my colleagues, my friends, for joining us today evening. I think we can close the session. Over to the organizers.
Thank you, Manish sir. Thank you all the faculty members, speakers for giving us the opportunity. And that was a very enlightening session. Thank you, sir.